Good morning, everyone. Welcome to session 2 of the day. We invite Dr. Archana Shah, Dr. Bharti Talolkar, and Dr. Monica Umbardan. Dr. Archana Shah is working as an obstetrician and gynecologist at Deep Super Specialty Hospital, Solapur. She has done her fellowship in high-risk obstetrics, a diploma in reproductive medicine.
Welcome, ma'am. Dr. Bharti Talwalkar, ma'am, is the owner of Talwalkar Hospital and director of City Hospital, Solapur. She is a past SOGS president and in private practice, she is working since last 35 years in Solapur. I welcome you, ma'am. And Dr. Monica Umbardan, I think Monica doesn't need any introduction. She is the best pillar I can say of SOGS. I welcome you, ma'am. Over to you.
Hello. I invite Dr. Sharad Gogate. This topic, multi-speciality tele-guidance service on fetal medicine and genetics for standalone practicing obstetricians. His fetal medicine consultant services from 2005 till today. Gold medals won at MD examination. Invited on the International Board of Advisor of American Journal and Obstetric Gynecological Society of 2 years in 2007. Awards, peer reviewer for Obstetric Gynecological International Journal, editorial advisory board member of MDC Current India, on board of reviewer of Indian Journal of Fetal Medicine, awarded with Mother Teresa Excellent Award in 2001.
My presentation is going to be rather bland. I am going to cover but it is very much important from the day-to-day practice point of view as well as comfort of the patient. Teleconsultation for patients as well as multi-speciality tele-guidance services in fetal medicine, genetics and high-risk obstetrics for stand-alone practicing obstetricians. Evolution of our tele-guidance program, the idea took roots during the COVID pandemic. COVID pandemic posed many logistic problems for doctors and patients. Non-COVID disorders and emergencies were put on hold. To give relief in this emergency, central government and Indian National Medical Council encouraged teleconsultation facilities and released guidelines for running the same in March 2020. This gave us legal and ethical validity and protection, and we launched these two very useful programs. Teleconsultation for patients for fetal medicine genetics. Normally, in-person consultation is preferred in clinical practice to establish clinician, patient and family rapport, bonding, and get complete information and permit thorough clinical examination. Since most of the patients were referred by some local obstetrician, there was no need for physical examination and they could be offered teleconsultation. The actual patient management remained with the referring clinician. Teleconsultation saves traveling long distances, time, expenditure, accommodation for patient and family, and need for consultation by multiple specialty also adds to these woes. Our model of multi-speciality teleconsultation answered most of these issues satisfactorily and made the process more efficient and cost-effective. Teleconsultation patients, as per 2020 NMC guidelines, information and guidelines were sent to the patient first, informed consent to be signed by the patient and family prior to availing of the facility, patient to submit all previous lab reports, imaging, scan reports, clinical notes, etc. by email or WhatsApp to the doctor conducting this, that is myself, After review of the above, teleconsultation by WhatsApp, video, Zoom, Google was offered by me, Dr. Sharad Gogate. Specialist opinion were obtained depending upon requirements by personal discussion before final sort of consultation was offered. A detailed document of evaluation, counseling, suggested management options and follow-up was prepared and signed and was forwarded to the patient as well as to the referring physician by email or by WhatsApp post. Hard copy of the same was saved in our clinical database, and patients were followed through clinicians and direct communication. This is the informed consent form which we have devised as per the guidelines. This is our experience of 236 teleconsultations in last 1 year. Geographic location, Mumbai, about 515 patients were from Mumbai, 74 from Maharashtra, 34 from other states and 13 from abroad from other countries. The indications for consultation: aneuploidy screen positive, maternal age 91, congenital anomalies 47, repeated pregnancy loss, ART failure 25, genetic factors in couple or family 23, preconception counseling 12, infection teratogenetic risk 11, immune non-immune hydrops 10, hemoglobinopathies 10 and others were 7. So you can see as a wide variety of indications were handled by us through this teleconsultation. Now I come to the second part, that is teleconsultation platform for fetal medicine, clinical genetics for clinicians with standalone private practice. In India, almost 50 to 60% of healthcare is provided by small standalone clinics and hospitals. They have limited infrastructure and handle low to moderate level risk patients without quick access to senior second opinion or tertiary level facilities. Because of this, they have certain problems when they are handling their patient and they don't know where to go. Our platform was very useful for such standalone clinicians as a quick referral facility wherein clinical details, investigative workup of complicated problem cases were forwarded on the group platform by the treating clinician, and our expert panel, after brainstorming, collective opinion about further management was offered. Clinicians were instructed to give close follow-up of these cases. Why the need for such a program? The clinical practice, laboratory investigations have changed rapidly. New fields, specialties like fetal medicine, ART, genetics have come into effect. Entry of new diseases, better understanding of diagnosis and management also plays difficulty because they can't keep on updating themselves so frequently. Clinicians get confused in their day-to-day practice and require guidance or senior opinion for proper evaluation and management, which is not easily available. This also adds to the cost and delay. A tele-guidance facility with multi-speciality faculty was found to be very useful for clinicians as well as for their patients in need of expert opinion. Telemedicine guidelines implemented by GOI and NMC 20 were encouraged and we followed them strictly. Teleconsultation platform for clinicians, Chikitsa Gogate Fetal Medicine and Genetics WhatsApp group. This is the social media group of healthcare personnel from fields of fetal medicine. Our expert panel is quite extensive and we could handle any problem that came to us because of associations of such wide variety of specialists. This forum ensured free discussion so as to provide quick and multi-speciality evaluation and management guidelines for practicing clinicians. Bulletins covering various topics of interest relevance were also posted periodically as CME activity. Now this is, so far we have about 440 active members on our WhatsApp group. Most of them are practicing standalone clinicians or PG students. And we also are conducting, as I told you, every month interventional procedure training forms. Most of them were encouraged to join this through Telegram. And we have about 730 candidates who are joined on this group. So together we have almost 1100 plus people who are making use of this consultation facility. As I mentioned, our experts are fetal medicine, so no, the list is quite long, but there is no field which is not covered. So that we are confident that we will be able to give appropriate expert opinion at a short notice to give the best possible result. We invited the relevant panel expert to participate according to requirement. This gave a final opinion by consensus and helped in seamless patient management. Close follow-up was maintained and outcome was also sort of sought out to see that how it helped. Before I go to a conclusion, I would like to say that I have got these two books which I have edited. One is Preventive Genetics and Update, which is useful for resident, means those who are appearing for PG examination. Second is a handbook of guidelines and standards, which is useful for practicing clinicians. It extensively covers all the aspects of fetal medicine, clinical genetics, antenatal screening, all aspects in a very multi-author book, which will be available and as a desk on your clinic table. If you keep it, it will be a valuable aid. So I request any of you who are interested in having these books, the publishers are going to give discount for both these books if they booked as a delegate for this conference. In conclusion, use of telemedicine platform has been very helpful for handling patients referred for counseling in these topics. It helped in reducing load on already overloaded MCH activities. Getting a sensible, holistic opinion for problem cases is always a challenge for standalone obstetricians. Our group was found very convenient, and continued attendance for workshop as well as enthusiastic participation by large number of clinicians in our activities shows appreciation and value of our program. I'll be going to the second part of my presentation now. कुठे आहे ते? Hands-on workshop. हाँ. This is activity which is being conducted for even just before COVID pandemic, and it's continued with a break during the pandemic period. What is the need for training workshop? Shortage of trained clinicians due to PCPNDT law stringent guidelines. As a matter of fact, we are almost, it's bordering on phobia. We are so much worried about PCPNDT that we don't want to give even anything out of the way for fear of being sort of censured by the PCPNDT law. Non-availability of MTP volunteers. When we were resident, we used to have a large number of MTPs first as their second trimester, and we could practice on them and hone our techniques. But now with availability of medical abortion as well as better contraception and number of MTP patients is definitely going down. Presidency programs don't include these procedures in their curriculum when it is most appropriate. Like you teach your student how to do a section, how to do a laparoscopy, how to deliver a patient. This can be added in there at that time only. During those 3 years, it is very possible for them to learn this technique. At the moment, the situation is आपल्याकडे मराठीत म्हण आहे ना, आई जेवू घालीना आणि बाप भीक मागू देईना. Residency level they don't teach, and when they come out with postgraduate degree, PCP, NDT doesn't allow them to do these procedures. So we have to find a solution. Till that time, we have to have some activity like this hands-on training workshop. Use of ultrasound guided simulators is a better way to train safely. Training on actual pregnant patient is difficult and problematic because nobody would like to hand over a patient coming for diagnostic test to a trainee because something goes wrong, you are going to be responsible. Use of ultrasound compatible simulators more efficient and safe. No local manufacturer at that time. Imported simulators are very expensive and difficult to maintain, and they don't last more than 6 months to 1 year and cost at least about 1.5 to 2 lakhs rupees. Develop our own simulators for transabdominal and transcervical procedures, reusable transcervical CVS cannula. These we could have an efficient hands-on training program. Structure of the workshop. First, it was a one-day program, and most of the students at Shikitsa had come for their ultrasound training. So during that training, we organized one-day workshop every month, and we have been doing it without any break for last almost 3 years. Genetic counseling with focus on interventional procedures, that was the first module. Then technical overview of prenatal interventional procedures for clinical practice. And then third was a tutorial for basic techniques and principles of interventional procedure. Hands-on training, basic steps for invasive procedures, planning the procedure, need for eye-hand coordination, visualizing and imagining in 3D. These were the basic preparatory steps. And after that, use of simulators for TA, transcervical procedure. First, we demonstrated the procedure to the trainees and by the trainer, and then the students practiced under their supervision till they had a basic understanding, and they could continue after when they went back to their practice. Profile of participants. So far, we have from 2019 to 2024, 760 candidates have been trained by us. 626 are obstetricians and 134 are imaging or radiologists. Already in practice were 307 and 153 were just finished postgraduate studies. Area of practice, 83 were from Mumbai itself, 184 from Maharashtra, and 488 from other states. You could see that we have a practically national level representation of our candidates. So they found it worthwhile coming all the way here because it was giving them valuable information as well as facility to train themselves. Post-workshop feedback from patients. Each participant gave a post-workshop feedback. 70% were said they were satisfied, very satisfied. 10% said that they were not very but satisfied. And the 15% said they wanted a longer experience on simulator. And only 5% said that they were not satisfied with it. All participants were added to our WhatsApp group so as to use the platform for their difficulties and suggestions, and they could also participate in our teleconsultation for clinician program. Follow-up home work to gain practice. Participants were encouraged to practice these techniques they learned, like transcervical CVS on MTP patients just before starting the procedure. So I tell them that you normally pass a uterine sound before you start dilatation and suction evacuation. Why don't you pass a chorion biopsy cannula? Your ultrasound machines are always there in our nursing home, and you can collect a small bit of and maintain a logbook so that what you have done, you can document it. Similarly, in second trimester, instead of using misoprostol, which is actually not authorized to be used for second trimester termination, we ask them to use intraamniotic prostadine injection, which is a authorized and certified method of termination. And also maintain a logbook and store procedures, images and short video. This much we have done, but ultimately whether the local authority will accept this or not, that is anybody's guess. So this is not ideal. Ideal will be to definitely include this program in their residency training program. I have been pursuing this matter with MUHS Vice Chancellor for last 2.5 years. So far, there is no progress. I hope now Milind, once he becomes Foxy President, he will use his good offices to put pressure on them to see that this training is included in the residency training program. These two simulators were developed when I was a consultant at CMAST, and Dr. Gadgil, myself, Dr. Raju Sahitya, as well as Mr. Sharma, who was the model maker. We collectively developed these simulators. The CVS cannula I developed when I came back from England in 1985, when I was with Professor Charles Rodek. And he has a Corion Willis cannula, transcervical cannula. I modified it, made it more affordable and more efficient. And that is how these things have been developed over here. Now, let us go amniocentesis. The simulator sketch diagram is shown, which how it is inside, and that is how the simulator is developed. This is actually the modified final simulator. Now we are using it regularly. We have a tap there so that in case we want to charge the fluid inside, it can, so we don't have to keep on waste, because in other foreign there is no charging facility. So if the water leaks out, you just have to throw the simulator and buy another one, so which we can't afford. This is a short video of amniocentesis. You can see the needle entering into the amniotic sac. Now here we always tell them to make an oblique puncture so that the chorion and amnion punctures are not overlapping with each other, so that reduces the risk of leakage. This is the transcervical. It will take about 5 to 7 minutes. You can see needle is already in the placenta, and then a to and fro movement, and all these things are demonstrated very nicely through our simulator, so that it is as good as doing it on a patient. This is transcervical sketch diagram, and this is our transcervical simulator. And this is a transcervical chorion biopsy cannula. It's a 16 gauge steel needle. The temper is taken off so that it can be bent depending upon the requirement. Both stilette and needle are metal, so they can be reused, and they give a stronger echo on ultrasound so that it can be seen nicely. And we have made the tip bulbous so that it is atraumatic and easily detectable from where you are taking the sample. I have been using this for last almost 30-35 years, and I never had any problem with it. This is how transcervical. Here we have done away with the vagina and holding the cervix, so we can demonstrate it more easily. You can see the cannula, we keep little fluid in the cervical canal so that for the person it becomes, training becomes easier. And we have said that you have to keep on gliding along the inner surface of the cervical wall so that you don't accidentally puncture the gestational sac. And you can bend the cannula depending upon the requirements of the uterocervical angle as well as the position of the, whether it is posterior placenta or anterior placenta. Again, the same appeal for books. In conclusion, use of simulators locally made is a safe and efficient modality to train clinicians for prenatal invasive procedures. Our simulators are efficient, affordable, easy to maintain. We have used them successfully in large number of participants with very encouraging outcome. There is urgent need to include training for prenatal diagnostic tests during 3 years residency program in obstetrics as well as imaging sciences. That is the long-term solution. I would like to thank Solapur Obstetric Gynec Society, particularly Milin and Monica, for inviting us over here. I am really very happy and pleasantly surprised at the camaraderie and the intense interaction and enthusiasm, and even the participation from junior people into the conference. The papers were of very high quality, even the poster. So this is how a conference is to be organized, like a model conference. Thank you.
Thank you, sir, for explaining very difficult topics in a easier way and which are very essential for today's practice.
Now I invite Dr.Sachiin Hongunitkar. The topic for his talk is Overview of Reproductive Genetic Test, When and Where. He is PhD in Clinical and Molecular Embryology from Department of Clinical Embryology, Kasturba Medical College, MAHE, Manipal. He is currently heading Anderson Clinical Genetics at Chennai and reporting of pre-implantation genetic testing and prenatal genetics for aneuploidies and monogenic disorders. He is certified genetic counselor from BGCI India and visiting genetic counselor at various hospitals across country. He is a visiting faculty at various centers like Mysore, Bangalore and Belgaum. He has undergone training for embryonic stem cells and cancer stem cells at Konkuk University, Seoul, South Korea, and he has published several international papers in reputed journals in clinical and molecular embryology and embryonic stem cells. Over to you.
Good morning, everybody. First of all, I would like to thank Milincha sir and Solapur Obstetric Gynec Society for inviting me for little bit of things on the reproductive genetics, what we are doing back in our lab in Chennai. So basically, I know everybody is familiar about the amniocentesis and NIPT and the CVS procedures and all what next. Yesterday, Jaydeep sir also told about the POC testing. So I'll be putting a highlights on whatever the advantages or the clinical significance of the genetic testing in the clinical management of this one. So at Anderson, we do many things in the reproductive genomics. We have been doing from past 10 years. We are much specialized in PGD and PGTA and PGTSR. Apart from that, female infertilities and the donor screening program, because donor screening in the IVF segment is something which is not many people are doing that one. So our focus is more on the donor screening, and apart from that one, we do sperm aneuploidy testing across with that one, and the sperm DFI by the flow cytometry, which gives a better DFI values. And today I will be mainly focusing on the prenatal diagnosis. This is on the other side across. So when we look into the prenatal diagnosis, we can tell it can be divided into non-invasive and the invasive. Everybody is aware of NIPS. And when we are talking about the invasive, it might be a 5 chromosome, it might be a 23 pairs of chromosome. It might be a 5 chromosome can be done by everybody is aware of FISH many people are using. But today I will be showing some interesting cases where the fish is really challenging. We need to think of doing an alternative segment across. Maybe a QF-PCR would be an alternative, that would be. And everybody is aware of karyotyping, but karyotyping is having its own challenges, especially when we are looking into the prenatal segment. And when we are talking about the advanced technique like microarray, how to address the microarray. I know microarray, everybody don't want to do it because probably because of the VUS variant, whatever it comes, whether to terminate the pregnancy or continue the pregnancy, that is the challenge. Same thing goes with the exome, when I should do a microarray, when I should do a exome sequencing, what kind of a scenario. We'll be discussing all these things in the bits and next few slides. As everybody is aware, the NIPS, when I am talking about it, it's a simple blood test which is done taken from the pregnant woman. It's basically a placental DNA, cell-free DNA, circulating DNA in the mother's bloodstream and collect the blood sample. There are two methods of the NIPT. Some people do by counting method, some people do by SNP analysis method. But when we compare both the technologies, the sensitivity, specificity still remains the same. The failure rate still remains the same. There is no change in the this one. So basics of NIPS, everybody is aware. It is a screening test. I have never used the word NIPT. I am using the word NIPS. So it's a screening test, and according to the ACOG guidelines, it is strictly should be used for all the pregnant women, immaterial of maternal age, immaterial of the pregnancy type. It should be used for all this one. And very importantly, it will be always helpful. You don't have to wait for the first trimester like a double marker, 11 to 13.6 weeks. Anything after 10 weeks, we can do an NIPT. The sensitivity is very good. And I'd never say that non-invasive prenatal screening will replace the amniocentesis. I would rather say it is an adjunct to the double marker screening, or it is an add-on step on the double marker. It has a better sensitivity than the double marker. Slightly, it might reduce the amnio cases, number of the amnio procedures, but do use it with the caution. And who cannot undergo the NIPS? Yes, the people who had the history of the previous cancers, leukemia, like that, because there will be abnormal cells showing the false positive data on the NIPS. So this is on the guidelines of this one. These are the recommendation as per as the ACMG, American College of Medical Genetic Guidelines. And this is a comparison of the markers and the NIPS. Yeah, it is a one-time test. If you look into the combined risk test, which will be around close to around 3,000 to 4,000, you will get a one-stop solution at the NIPS at the one-time test across. And yes, there is a challenge of sex chromosomal abnormality. I think yesterday it was discussed over the panel discussion also. So sex chromosomal abnormality for the NIPS, still when we look into the PPV value, it stands almost like a 50%. It's like a tossing of a coin. And when we are looking into the this one for 13, 18, 21, for 21st chromosome, the sensitivity is around 99%, and I do not recommend using a microdeletions by NIPT, although 22q.11 for the Dijot syndrome, when you have a ventricomegaly kind of a thing, you can use it on the caution front, but still, I would still believe on the amniocentesis for that one. So this is about the sensitivity and the positive predictive value of the, and the negative predictive value of the NIPS. With the, when you see in the sex chromosomal abnormality, the false positive rate is slightly on the higher rate compared to that of the other chromosome because of the Y chromosome nature, because the Y chromosome is so small, the markers on the DNA markers on that one are very limited. So that is one of the reasons for the sex chromosome abnormalities, the sensitivity slightly goes down across. So NIPS, when not to do, strictly when a USG abnormality or the soft marker is there, I would not recommend to do an NIPS. I will reconfirm, because I have seen so many cases where the patients have undergone the NIPS at around 11 to 12 weeks and it has come out to be a normal. And when they go to the anomaly scan, in the anomaly scan they will see one or two markers like echogenic foci of the kidney or something comes on the cardiac foci. That time, should we do an amnio or not? Because already for the chromosomal abnormality we have done a NIPS, it is showing absolutely normal. Now, is it the chromosomal abnormality will be changing? That is a challenging point of it across. And also, as I mentioned about the previous history of the blood cancer, where the leukemia cells will be there, which will give a false DNA and it will increase your false positive rate. Multiple gestations, when I am talking about the triplet pregnancy. Twin pregnancy, it is better, but not more than twin. Although even in the twin pregnancy, it will not tell. For example, if any abnormality comes, still you have to do an amniocentesis to confirm which is the baby. We need to look for the fetal reduction if it is abnormal or whatever the prenatal intervention procedures. So these are the different panels, basic and this one. 5 chromosome is the most common one. Advanced is 23 pairs. Comprehensive NIPS, I don't strongly recommend, but it can be offered across with that one if it is needed as a kind of this one. And coming to one case study we had done, I was telling the example, one 27-year-old non-consanguineous couple had come for an NIPT. They had already done an NIPT when the anomaly scan was showing about the nuchal fold, persistent SVC and the polyhydramnios. When we did an amnio, I would still prefer to reconfirm by doing an amnio. We found there was a 10 MB gain in the 19th chromosome, which was not there. However, even at that particular, for example, we had done a NIPT for this patient twice. In fact, the 11 to 12 weeks, the NIPT was done at the 11 to 12 weeks, and even at the 18 to 90 weeks, still the results were normal only, but the amnio was picking it up. This is something which is very, very important to select the patients. If a USG is any soft marker is there, straight away go with the invasive procedure. I do not recommend for a NIPS. Yes, it can be offered as a screening when there is no ultrasound abnormalities are there. Then we had to look for the parent. However, it was a de novo variant. Parental karyotyping was absolutely normal because I hardly see any kind of a abnormality coming, originating or inherited with this one. Moving to the invasive testing, everybody is familiar about the FISH. Everybody knows that fluorescent in situ hybridization technique, it will reduce the time on detecting of 5 chromosomes. It will quickly tell across. But at the same time, FISH also has a challenge. It cannot be automatized because of the manual intervention is there. We need to count each and every number of signal, and it is a time-taking procedure. That would be one of the major challenge. Recently, we encountered one case. I will be discussing about that part. There is an alternative method of a QF-PCR or a quantitative fluorescent PCR. This also tells about the 5 chromosome. The turnaround time is more important of the QF-PCR. It is 1 day. The FISH will take as well as 2-3 days. It has a better diagnostic yield. When we see 2 peaks of the equal height, it shows as a normal, or a different size of this one, it will be showing as abnormal. Now, why I am saying as a better diagnostic tool compared to that of the FISH? I'll give you an example. I had a case actually, a 27-year woman came for a amnio. The sample came at 22nd week. I did a QF-PCR. It was showing some kind of 4 markers was showing abnormal out of 6 markers, and another 3 markers was showing normal. As a routine process, FISH, everybody knows that FISH is a golden standard. So I did a FISH for that. FISH is showing absolutely normal. Then we were concerned that, okay, fine, the best accurate technique would be a microarray. We will do on microarray and the karyotyping. When I looked into the microarray, karyotyping, I'll come back to you later. Microarray was clearly showing there is a likely pathogenic gain of around 14 MB size across, clearly visible on the 21st chromosome. This was something where the FISH was a false negative. QF-PCR was able to pick it up, and karyotyping, however, we had done a microarray that was able, but on a given day for any kind of a cytogenesis, if I give this kind of an image, 8 out of 10 would be telling that it will be a normal only. So the karyotyping and the FISH was a challenge in this kind of a scenario where the pickup rate would be a major challenge. So only advanced molecular techniques are the better. Now the comes across, I will be talking about the microarray in the next, I will be talking about the VUS also. So this is about the QF-PCR. Everybody is familiar with the karyotyping. I would strongly recommend doing a karyotyping for all the parental sample, not the parental samples for the blood karyotyping, but and as well as the amnios, because it has one unique nature. None of the advanced molecular techniques can detect it. That is, it cannot detect any balanced kind of a translocations. When we are looking into it, the disadvantage, again, it will be the reporting would be around 14 to 21 days because of the culturing time. Microdeletion duplication of the lower resolution size, we cannot detect it. Reporting time, as I have mentioned about it. But again, translocation, it can detect it. So to overcome these culture failure risk and the microdeletions and duplications, people started to move to the microarray, which is a more advanced technology or a high-end technology. We can say that it will be able to give the better resolution on that one. So this is a chip of the microarray, what you can see it across, and where you can see the DNA, this one is posted on the, it is placed on this one, and when you add the sample, it binds it and gives the fluorescence for it. There are two types of microarrays. I think people might be aware, array CGH and the SNP array. SNP array gives more information compared to array because it is a whole genome coverage, whereas this one is a very targeted region coverage. And also it will also help in to identify the loss of heterozygosity or gain of heterozygosity, that especially when ROH value will be higher when it is a consanguineous couple. We see a lot of, it will be helpful especially when I am doing a product of conception testing, where it will indicate whether should I do the next tier of testing of a exome sequencing or not. So as I mentioned about the clinical reporting of the chromosomal microarray, as far as the ACMG guidelines, we need to classify into the benign variant, likely pathogenic variant, and the VUS variant. When I am talking about the VUS variant, now many people are concerned that, okay, what should we do when it comes, should we continue the pregnancy or should we terminate the pregnancy? Let me come back to the data of whatever we are doing. We have done around taken the data of last 2-3 years. We were seeing around 5,000 CMAs. This incidence of the VUS was less than 2%. Where for the prenatal cases. So these 2% of the cases, according to the guidelines, we cannot terminate the pregnancies. That is what we have to counsel the patient. That is a clear-cut what is the risk factor associated with that one if they continue the pregnancy. If they want to terminate, it is their choice across. But as far as the guidelines of the ACMG or ACOG, it does not recommend to terminate the pregnancy. Again, a case study of the microarray where a karyotyping was come across. It was absolutely showing me a normal. I think the indication of this case was a unossified nasal bone, and one more ultrasound soft marker was there. When I did a microarray, there was around loss of 623 kb. It is a very, very minute size. Again, it is associated with the neurodevelopmental delays and some kind of a neurological problems also. So this is the advantage, or a microarray has a better diagnostic yield compared to that of the, or a QF-PCR plus microarray would have a better diagnostic yield compared to that of the FISH and karyotyping. We will not miss any of the techniques. And whenever we have a doubt on the internally, whenever we are suspecting any kind of a marker, so we have many other alternative methods to reconfirm and then only report it, so that it will be helping to counsel the patients also. And what is the standard diagnostic algorithm? Is there any fixed algorithm? When a pregnancy is established, double marker or triple marker, nowadays nobody is using it. In fact, quadruple is a more recommended because of the sensitivity. If it is coming as a high risk, go for a NIPS, probably without ultrasound abnormality, or else straight away go with the amnio. If NIPS coming out to be a higher risk, do a rapid aneuploidy testing by QF-PCR or FISH, or do a karyotyping or a chromosomal microarray. That would take care of that one. And if it is all the low risk, then go ahead, or any of the step, it is a low risk, you can continue the pregnancy, where 99% we should not have any problem. Or if it is abnormal, counsel the patients accordingly, or post-test genetic counseling can be recommended for it. Lastly, I will be looking about the exome sequencing. When we are seeing about the whole exome sequencing, it is recommended, or a point mutation when the parents are the carriers of any kind of a single gene disorders, or there is any history of a family history of any kind of a neurological disorders, or any kind of a thalassemia, or the sickle cell anemia, cystic fibrosis, atrophy, muscular dystrophy, whatever, any disease which is following the Mendelian pattern of inheritance can be strongly recommended for the exome sequencing, either at the amniotic fluid stage or at the stage of the POC stage. Now, lot of fetal medicine or lot of gynecologists asked me, can I do the amnio directly exome? I don't want to do a trio sequencing because trio will be expensive, because it always helps trio sequencing, it always helps for the post-test counseling. It will help whether to continue, because anyways when we are benefit of doubt, the trio sequencing do help it across. Maybe the parents should be tested prior or the after, because it will add a value for that one. Yes, there is a cost factor concern with that one, so that can be handled across. And lastly, I will be talking about the POC and the DNA storage of the POC sample. This is something which is very, very important. Everybody looks into the chromosomal microarray for the aneuploidies, but most of our first trimester miscarriages, 50%, I will show you the data what we have done in our lab. 50% of the first trimester miscarriages are the aneuploid POC samples, and also most of the antenatal, 32% of the ultrasound abnormalities are seen in the first trimester, and also 5% of the cases are associated with the balanced translocation carriers also. So this is the ideal for, especially for the IVF conception ending up of the pregnancy loss because of the chromosomal abnormality in the embryos. That was the probable reason, or abnormal fetal sound, that would be a parents with the known balanced carrier. Definitely there is a this one, and advanced maternal age. And when we look into the clinical significance of the POC testing, why we have to test for the POC? Is it so important? Does it give any information? I'll just throw a light. It is up to us whether to take a call, whether should I do a POC testing or should I not do the POC testing. When it comes as a no significant variant, see it was a negative, what next to be done? Then I would go with the second tier level of testing as a POC exome sequencing, or you can do a combined exome plus a microarray, that because patient does not want to repeatedly come for and do the test. So that is also a challenge on the patient counseling on the financial part. That would be if a mutation is positive in the microarray, then in the exome sequencing, parental screening is recommended, because probably there will be a carrier. So if it is an autosomal recessive condition or a X-linked recessive condition, or genetic counseling, if it is a mutation negative, probably look for a biochemical marker, Saplar or lupus anticoagulant, making sure that everything is fine on this one. And you can, if at all it is a single gene carriers, if the parents are the carriers, opt for them for a PGTM or a prenatal diagnosis with the next natural conception if they are undergoing, or a IVF with the PGTA and PGTM, that would be also. Now, when it comes as a likely pathogenic CNV, what will happen when the parental CKT or CMA, I would not recommend a CMA. I would, it depends upon the resolution, I can say. CKT is the ideal option for that one to see the recurrence risk. And if it is a high recurrence, do a phenotype-genotype correlation, recommend for a PGTA. If it is a de novo variant, just ignore it. It is a chances of inheritance will be very, very lesser for that one. Now, this is something a bottleneck whenever we get a CNV of uncertain significance, where we usually still recommend parental CKT. Make sure that it is all about the counseling, especially in the VUS. We need to understand all kind of, when I see the data on the VUS of the prenatal cases of the chromosomal microarray, it is less than hardly around 1.5 to 2%. So 1.2%, but when we see the diagnostic yield of a chromosomal microarray when compared to that of the karyotyping, it has a better yield than the karyotyping. So that 2% by counseling, if we can address that one, I think chromosomal microarray would be a better test actually. So this is about the POC CMA testing, the diagnostic yield I was talking. I had classified into different types based upon the gestational age, maternal age, and the pregnancy type. When we look into the gestational, first trimester as having a highest kind of abnormality of around 60%. When we see the immaterial of the, yeah, just a minute, I'll finish it. And maternal age, when we are looking into it, less than 35 was still around, it is not dependent upon the age also, I can say it across. Abnormality is around 48%, whereas more than it was going up to 68 to 70%. Now, when I look into IVF pregnancy or a natural pregnancy, you can see the abnormality rate is almost standard around 50%. So, immaterial of it is a natural pregnancy or the IVF pregnancy, status unknown, I can say that we are not aware of what kind of a pregnancy. That information they had not given in the test request form, so only I kept that one as a separate criteria. So immaterial, whatever it is, 50%, that gives an explanation to the patient that yes, there might be a genetic abnormality, we need to screen for this one actually. Yeah. Coming to the last part, we have talked about so much of techniques, so much of tests, which test, when to recommend. I'll be busy with the OPD condition. We need to think of somebody. If somebody is helping over there for the genetic counseling, it is one of the specialized branch or the science helping the individuals or couples to do understand the genetic aspects of the illness, where we have a specialized BGCI counselors who take the family pedigree chart, draw down the history, understand, explain what are the risks associated, what are the reproductive options available, whether it is for the donor, whether it is for a PGTA, whether it's for a PGTM, whether it's for a prenatal testing, what best would be a right test for them to take a call further with that one. So this is something when to consider it based upon the family and the genetic risk. That is what we need, and these genetic counselors work as a member of healthcare team, and they provide a support to the clinical team and as well as the patient to understand, and they can take accordingly select a right reproductive options and the correct preventive measures for that one. So this is from my end. If anything is there, I would like to take questions. Thank you.
Thank you, sir, for the very informative talks on genetic testing and especially about the role of genetic counseling. Thank you.
Let us now move forward for the next academic topic, the late detected fetal anomaly challenges for clinicians, which most of us face, and yet we have to answer the relatives sitting in our OPD chambers. To address this, we have Dr. Vandana Bansal, madam. She is a professor and head of the ultrasound department at Naurozji Wadia Maternity Hospital. She is currently the president of the Society of Fetal Medicine Mumbai chapter. She is a member secretary of Expert Ethics Committee, chairperson Fetal Medicine Committee AMOX, national coordinator for the Imaging Science Committee in 2018 to 2020. Madam has more than 60 publications and 30 papers in national and international journals, and she's contributed to more than 21 chapters in various books. She also has a Springer Best Publication Award in 22 to 23 and various paper awards at MOGS, ISOPAG, and the Dr. D.K. Tang Best Paper Award at MOGS. We welcome you, ma'am, and you can start your session.
Can I have my slides? Yeah. So I am an obstetrician and a fetal medicine specialist. So we all fall into these problems when we have a late detected anomaly. So I am going to take you through the eyes of a fetal medicine and the work of an obstetrician and how we go ahead with cases where we find them out a little late in pregnancy. So we all know the statistics are there that we have about 8 million infants are born with birth defect, and India is one of the top among them also. The problem is with the babies which are born and they live after birth. The ones which are born and are lethal may die and may not be so difficult to manage, but the ones where the babies are living and they have morbidities and which the parents have to go through is a huge number among all of them. So we need to get these babies which are anomalous, which are late detected, what to do for them, how to bring them out in the best conditions so that they don't have morbidity. So our traditional timelines are we do everything in the first trimester, the standard, and we also look at anomalies in the first trimester and the screening for aneuploidies. Then our basic anomaly scan at the 20 to 22 week scan. And the growth scan later on is basically only for growth and Leica and surveillance and not for anomaly scan. So there is a whole U-turn about this that we used to start off because the machines were not good, so we used to see scans more in the later trimester. Then we came to first trimester, we can do everything in the first trimester. And now we've taken a U-turn and we want more scan also in the third trimester, so the focus is back on the late trimester. Why so? Because in the Mecca of fetal medicine, King's College also, 25% of cases were first detected at 35 weeks, where they are the best fetal medicine people. And in Indian scenario, this is work from Lucknow, 70% diagnosed after 20 weeks. So a lot of them could have been diagnosed, almost 66% of them, but were missed. So in India, there is a big load of these cases which are late detected. So late detected can be evolving, That means they were not there at 20 weeks and later on they develop like microcephaly, ventriculomegaly, craniosynostosis may not be seen at hydronephrosis. It could be just normal and later on developing, and skeletal also. And there could be new development like an intracranial bleed suddenly comes up in the third trimester, or an ovarian cyst suddenly comes up in the third trimester and it wasn't there early. And some which are missed by whoever has done and it has got missed. So these are the 3 types of disorders. Majorly CNS, cardiac, renal and skeletal are what gets missed out. So they are disorders which can be lethal, they could be morbid, correctable in utero, resolve antenatally, worsen antenatally, and maybe a new finding comes up. So these are the kind of disorders which we will find as obstetrician when a report comes to us. So first thing, how do we manage them is find out, is it lethal or highly morbid or not compatible with life. We can counsel the parents on termination and things. And whether it's associated with some anomaly and IUGR also, then our kind of counseling is going to be different, our management is going to be different. Whether it is associated with a genetic evaluation required or not required, then we have to talk about procedures and what can be there associated. And if we plan to continue, how do we follow them up? And if we are following up, where do we deliver them? How do we deliver? And when to deliver them? So basically, this is a gist of my cases that I'm going to show, and where what helps us in what things. These are all lethal, late diagnosed, full term and diagnosis, so not accepted, but yes, they are lethal, they will die in utero. Highly morbid, almost all of them are term pregnancies, missed, very difficult to manage them, but yes, morbid. But the ones what we can do best is, we want to manage these broken expectations of these parents who come with for an anomaly scan and we say, oh, we found this new thing, what to do about is, first diagnosis, very useful, because we need to have something that parents should know about it, help prognosticating, prepare the parents also. If genetic test required, we do that. If we require termination by court or by medical board, then that needs to be done. But if it is something which is correctable and we can manage them, then we monitor in utero. We could do some medical treatment and some surgical treatment. So basically, for all our anomaly scan, this is what we are going to follow. And for that, it cannot be one person job, it has to be a team which is managing it. And so I show you cases, and where what helped us is what I'm going to do. First we go with some CNS cases. All are ventriculomegalies, but everybody with a different presentation. So first one here, she is herself a doctor, 40-year-old, ventriculomegaly, severe IUGR, high umbilical, normal uterine artery. So severe IUGR with ventriculomegaly, I am suspecting infection. So she might not have it in the first, in her anomaly scan, and now at 30 weeks of gestation, I see this ventriculomegaly. So my first thinking is that it could be an infection. But what do I do at 30 weeks? 30 weeks, if I do a torch test, everything is going to come IgG positive. So we had that same IgG positive for all of them. Now what to do? Do I do an avidity test? So avidity is telling us, if it is low avidity, that for past 4 months there was infection. But if it is high avidity, it is before 4 months. So 4 months is still the first trimester. So here avidity is not going to help me much. So either I do an amniocentesis or I tell the parent, we could have an infection, we'll see at birth. She was a doctor and a professor in a medical college. She said, whatever it is, it's an IVF conception, I want to do best. So we will monitor her. So monitor her with Doppler, IUGR is there, absent flow. Ductus is still normal, I'll pull it a little more. So we took her till 32 weeks. Now the ductus is showing reversal, and look at how the baby is growing. Significantly less. But yes, the parents were ready. They were ready that it could be an infection. They were ready, they wanted the best out of this in a tertiary care center. So a 650 grams baby, 32 weeks, and this is how the baby came out. We tested the urine, CMV positive. And so she was started on ganciclovir. She was a shunt was put in. She was managed and she did well. So the parents keep sending me pictures saying, you said the baby was very bad, but this is how the baby is. I am very happy with what I have. So sometimes the parents need to be given the decision. They have to be educated enough to understand and understand the finances also. So a late onset CMV infection, but the baby did well because the parents were ready for it. So late another anomaly, where the parents had to make a more difficult decision. So here she came to me, DCDA twins, NT was normal, dual marker was high risk, and one fetal demise of the DCDA. So actually the dual marker should not have been done only because there was one IUFD. So we did a CVS, fish, KT normal, so we said all good, come back at 20 weeks for an anomaly scan. She did not come and came at 30 weeks to us. So now 30 weeks, ventriculomegaly. This is an agenesis of corpus callosum, a teardrop-shaped ventricle. There was a cyst in the ventricle also, and megacisterna magna. So now our karyotype was normal, but this has something else we have to now manage. She said, you did a karyotype, everything was normal. Now why is this come up? Because she didn't come for that anomaly scan and was missed by whoever has done. So now what can we help her? She's 30 weeks, she's got a ACC, prognosis is bad, mental retardation risk is 25%. So she decided to go to court, that time it was court, now it is medical board. And she got a termination order during COVID time, and she reached us at 34 weeks because while she was going around the government hospital and she got COVID during that time. So she came at 34 weeks for a termination with a letter saying terminate the pregnancy. So there was no offer of what to do. The baby will come out alive. So we decided we will do a feticide inside and also do a cord blood sampling at the same time. So a feticide, that is KCL, was put in and then terminated. And we still need to know whether it is going to happen again or not happen again. And so a microarray was done, and there was a microdeletion 17q. So now the recurrence, you need to see the parents were normal, so we can go ahead. So here, how did obstetrician, we helped her is, we got her through these court orders and got her terminated, got the feticide done, wanted to know the recurrence for next pregnancy, and now the recurrence is not there because parents are normal. So we can tell them next time, nothing to be done, you can manage it. Again, a case of cyst in the brain, which was a vein of Galen, seen in the 3rd trimester. We only had done her anomaly scan, which was normal, but vein of Galen usually presents in the 3rd trimester. So here monitoring is to look for cardiac evaluation more, rather than only look at the brain size. The size of the vein of Galen is important, but the cardiac part is more important. So you need to have a whole team as well as monitor the heart for these cases and how long to go ahead. So here, in this case, we went on till 36 weeks. So we had a neurointervention team ready for us. The obstetrician, we managed it. The pediatrician, the NICU, and the intervention team is required because you need to go into the vein and get the shunt done as well as to get the embolization done for this. So here the team was important. So the diagnosis was important because we had the team ready and we could manage this case. This patient had 2 previous neonatal deaths. She came to me at 24 weeks, said, we don't know what happened to both of them, but they said Dandy-Walker malformation, but nothing else, I don't have anything. So we just did a scan and the cerebellum was normal. So we said it doesn't look like, we don't have an index case worked up. That time exome, trioexome was not available. So we said, let's follow it up, MRI was normal. So she was all good, and at 37 weeks, suddenly came with decreased fetal movement. And on scan, there is huge intracranial bleed. The baby was almost floating in the water with normal Doppler, normal Leica, normal growth. So it was something that is like a perinatal stroke which happened. So there was a large intracranial bleed, and the baby, within half an hour, we could wheel her to the OT and deliver the baby. The Leica was clear, the growth was okay, the baby was pink, but it was completely like a stroke baby, and so we could not salvage it. But yes, we kept the DNA saved for management. So now coming to some cardiac cases. DCDA twin, IVF conception, 17 weeks, both twins completely normal. And then at around 22 weeks, This is not an echogenic focus. This is a tumor. It's a cardiac rhabdomyoma. Don't miss them and say it is echogenic focus. And so rhabdomyoma. One baby having rhabdomyoma, second baby was normal. This is more associated with tuberous sclerosis. Do I test both of them? Do I test one of them? We tested the one which had the disorder. And yes, it did come out as tuberous sclerosis, and you can see the size of the tumors have increased as we go ahead. So you need to follow them up for cardiac dysfunction and for hydrops, and to see for brain, for tumors in the brain also. So this was an autosomal dominant disorder. The recurrence risk is 50% if parents have it. Here the parents were normal and the second sibling was also normal. So the recurrence in next pregnancy is going to be less. So we can just monitor it. Again, a cardiac abnormality which requires monitoring is this tricuspid regurgitation or Epstein's. Anyway, a bad prognosis, but if we pick it up late, then you need to follow it up for hydrops. And if there is hydrops, the prognosis is much, much more bad. Coming to something which is correctable in utero. So this is a cardiac abnormality, a supraventricular tachycardia. If you see, the heart rate is around 225 or so. If you leave it like this, they will have contractility problem, will develop hydrops later on. And so if it is constant, you need to manage it. And so you could give her digitalis, or you could start on flecainide or hamideron intrauterine also into the fetus, and the heart rate became back to normal. So certain disorders resolve. So not all tumors are bad. So here you have a huge mass in the lung. You can see the whole lung is occupied by this echogenic mass, and the heart is squashed to one side, very, very bad cardiac dysfunction. The CVR we look at is the volume of that abnormal lung that we have, which was increased. But yes, it can still be managed. So we told her, let's wait, let us monitor. You could do expectant management. You could give steroid, as what just now Vaishali said. This is also an indication for steroid. And sometimes if there is a cyst, you can put in a shunt. The same patient. Can you believe these are the same lungs? The heart has come to normal. She's reached 40 weeks and we delivered her again in COVID time. So how bad it was to start with. The heart was on that side and it is completely normal. So CPAM is something which resolves. So CPAM, how bad it is, you can monitor them. Here again there is a cyst in the lung. CVR, again, CVR is 1.2. 1.6 and above is bad. You might need to put in a shunt. Sometimes you need to follow them up for hydrops. This cyst did not go. It did not go even till term and had to be operated. But then also the baby did well. Lung is something which is very grateful that it allows you to grow back again, and so the baby did well. She is an orthopedician's wife. I have a lot of doctors having anomalies. I don't know why doctors have more problem than the others. So there was a pleural effusion we saw at 21 weeks. So we counsel probably infection, probably Downs, Noonan, lot of things. So we aspirated, but at the time, he was a doctor, they wanted everything to be done. So we did a fish, torch, karyotype, microarray, exome. All came normal except it was Noonan syndrome. So structurally completely normal, only pleural effusion, and because it was Noonan, they filled up again. The fluid filled up again, so there was no use of doing a shunt in this. They terminated the pregnancy. Coming to bowel now, the ones which are higher up diagnosed early, present early, but the ones which are duodenal or lower down present very late. So these are the ones which have a problem. Especially duodenal atresia, one is diagnosis not difficult, but it presents late. The problem is you need to do an amniocentesis because high risk of Down syndrome in these babies. And here in this patient also, in addition to seeing the double bubble sign, there was a VST also. And then finally it did come out as trisomy 21. This was a time termination was not allowed. She was allowed to deliver. And then the ethical problems of do we operate on a Downs baby or not. But yes, they were operated upon. Downs is something which can be taken care of. The ones which are lower down, jejunal ileal, this is early malformation is normal and then there is bowel dilatation. These are usually not associated with genetic problems. These just have to be followed up for the dilatation, followed up for meconium and for any perforation. You don't have to deliver them immediately. You can take them till near term. You can have your team ready with your pediatric surgical team ready. And you don't need to do a section for them also. You could allow them normal delivery. So except for cystic fibrosis, they are usually not associated with aneuploidy. And this baby was born, the GI team was ready with us, and we could operate on this baby and do well. Meconium cyst is something very rare, but it is seen. And we looked at our own cases. The ones which were small meconium cyst resolved by the time she went till term, which were late diagnosed did not resolve, and the ones which were huge in size had hydrops. So it depends on the size as well as when it is diagnosed. The meconium cyst also will resolve in some cases. And so a case like this was hydropic and did not do well, while the rest of them really actually did well. Omphalocele, very simple, diagnosed also early, but should be associated with other abnormality and with chromosomal abnormality. Here the size of the mass, we need to not rupture the membranes, we need to deliver them at term, and for normal delivery may rupture the membrane, so it's better to do a cesarean section for omphalocele, and you need to do a genetic test. So here this was the membrane over that, and baby did well. Gastroschisis on the other side, bowels are all open, so you have to look for obstruction, you have to look for any dilatation and perforation in the gastroschisis, not associated with genetic problem usually, and so you could just prognosticate that they do very well actually. And so the baby was born full term, don't deliver early for any reason, and the baby did well, and the gastroschisis was managed. But on the other side, sacrococcygeal teratoma. This was a Dubai patient, again came in COVID at 35 weeks with hydrops, with polyhydramnios. So this sacrococcygeal teratoma needs to be monitored for hydrops, and then this was operated. You look at that area which was operated, and actually finally the baby did well. So last one case, it's a shared decision, twin pregnancy, one baby normal, one baby had a PU valves. So 24 weeks, do I reduce one baby? Do I continue both? Do I deliver them early? Because one kidney was very bad and the other was a good baby. So they wanted one baby to grow till term and one baby, let whatever happens to the baby, we go with that. So here this baby had echogenic cortex, at 27 weeks, then urinoma developed, then bilateral urinoma developed, then LICA went off, the kidneys became all conked off, but finally we delivered her at 36 weeks, thinking that one baby is going to be very bad and one will be good, but both babies were good, but yes, they required shunting, they required a valve fulguration, the creatinine was high. They sent me saying, guess which one was the one you said was bad. Actually, both of them are such beautiful babies, but that is what they decided. They wanted a term. So in twins, it is more difficult with anomalies, but you need to go with whatever the parents are asking for. Last one case is a team approach. She was hydropic baby, large tumor in the lung, extrapulmonary sequestration, severe pleural effusion, hydrops, and there was one vessel which is going to this pulmonary sequestration, completely edematous, hydropic, 28 weeks. She said, I want to do best for this baby. So we thought, let us put in a shunt and see whether it helps us. So we actually went in and put in a shunt into the pleural fluid, and we were able to aspirate it completely and have the shunt in place, thinking things are good, we have done a great work. It was good for some time, but in about 3-4 days it filled up again because that mass was there and that mass was causing the pleural effusion again. And so we decided 29 weeks, steroid Maxel given, that we deliver her. So on delivery here, again the neonatal team was in the OT, in the area of the table. We aspirated first and then did a section so that the ventilation can be better. And then they intubated the baby as soon as the baby's head came out, like an exit procedure. And this team approach helps. Look at the baby is quietly hydropic, and then in day 8, that pulmonary sequestration was operated upon in a baby who was just 29 weeks, 1 kg baby, and did well. So it is actually one of the smallest. It has been published again in International Journal as the smallest neonate who is antenatally diagnosed, and baby did well. Last of all is one case. This is interesting for us also and for all of you maybe, is if there is a conjoined twin and the patient wants to continue and we have no method of terminating, then what do we do? So this was a patient who had a liver which was fused, portal veins were fused, and there was one cord which was coming out from that which had 5 vessels. So how to manage with umbilical artery? There were 3 umbilical arteries, 2 veins. MCAs were different, yes. So MCA and umbilical artery. Do we do an AFI? No, because it's one sac only. Does it get TTTS? Does it have IUGR? Does it have anything else? No answer. There's nothing in internet, nothing written anywhere. They were a Catholic parents. He wanted best for that patient. So we monitored with an umbilical artery, an MCA, and an AFI for all of them. So now we've reached around 34 weeks. Do I deliver at 34 like an MCMA, or 36 week, or 37 week, or 38 weeks? 37, 38, baby will become very big. 36, 34, the segment may not be so well formed. So we decided nothing in literature again. 36, 37 is when we delivered. So whether we do a classical or lower segment, again no use, nowhere, nothing, nobody could give us help. And whether vertical incision on the uterus or not. So all those things were there. The team was ready, the anesthetist, the pediatric team, and we were there. So we had this 4.5 kg conjoined twins which were delivered, and they all had 5 vessels, and all of them, it was only the liver which was fused. So we took out one head, then the body, and then we rotated the head, took out the second one, and then last the head. So it was a fen and steel incision, slightly bigger in size than what normally we do, dissected it more, lower segment only, and we could take out these babies and brought them out. And our pediatric surgical team was all ready. It took them 6 hours to separate them, and it was published in newspapers all over. So my last slide is, there should be a scan which is done in the late trimester, definitely required. Earlier it was only for growth. Now, yes, we need to see for anomalies. So it has an additional benefit of diagnosing some undiagnosed anomalies. We need to then tell the parents also. The parents are more prepared. Monitor that abnormality, maybe in utero transfer, timing of delivery is important. The team is very important. Sometimes need therapy we can do, and legal terminations can also be done in these late anomalies. It has become a little more easier now to do it with medical board. Terminations even for pregnancies, even 34 and 36 weeks also, we've done termination when it is very bad, like microcephaly or skeletal dysplasia. So we need to have a realistic picture of our expectations in a prenatal diagnosis. 22 weeks, 20 weeks is good, but also see everything again at your 34 to 36 week scan. So thank you for a patient listening.
Thank you, ma'am, for the wonderful presentation. Late detect anomalies is always a question mark and difficult to manage, and you did it so well. Thank you for the cases and presentation.
Thank you.
Thank you very much, ma'am. I invite Dr. Tadwalkar madam to felicitate Dr. Sharad Gogate, sir.
Dr. Milind Shah sir and Dr. Neeta Ghate ma'am, please join her on the dais. I request our chairpersons, Dr. Archana Shah ma'am and Dr. Monica Umbardan, to join them.
Yes, you can. Yes. Yeah.
Video मध्ये
Yes.
खराब दिसते म्हणून बनतो.
Thank you very much. You know, friends, we have an association since last 25 years. Rather, my first entry in ISPAT was because of Dr. Sharad Gogate. and eventually it became more strengthened because of Dr. Raju Sahitya. And I'm happy to tell you all that coming year I'm taking over as the president of ISPAT. So we'll definitely work more. Sir, you'll have to come again and again here to Sholapur. And his Chikitsa is really wonderful center, I would say. My both daughters, Bella and Naval, my son-in-law Atishay, all of them, they went there, they learned advanced ultrasound. And the way they insonate the vessels, they do the Doppler, they do the invasive procedures, I get mesmerized ki how in short period they learn so much in just 2 actually months period. It's really wonderful center, sir. Thank you very much. Yeah, Anirudh and Kalpesh, everyone actually, yes. Yes, great, yeah. Thank you very much.
Thank Solapur Obstetric Gynec Society for this wonderful scientific feast. And a lot of efforts have gone, and even the social programs, yesterday's parade, fashion parade was amazing.
Good.
Yeah, heartiest congratulations.
Thank you very much, sir. Thank you.
I request Dr. Milind Shah sir to please felicitate Dr. Sachiin Hongunitkar.
Yes. Yeah, wait 1 second. Yeah. See friends, Sachin and I became good friends, and he's giving us actually wonderful advice since last almost 7-8 years. And I'm very much happy to announce that from coming year 2025, for every 4th Sunday, Sachin will be visiting Naval Maternity Nursing Home to give the services to all actually the Solapurettes and nearby actually places for genetic advice, counselor and all those tests, because he must be feeling that every time the patient comes, I used to bombard him with a lot of questions, what actually I need to do and all those things, especially DNA storage when we started. His help was very supportive. Eventually when I gave it to the many other hospitals, like when I went to Ashwini, Dr. Hirekar was so happy, he said, sir, मुझे लगा ये अपने यहाँ नहीं होगा, मतलब अपने यहाँ होता है, just to collect the sample and send it, and they started actually in Ashwini also now. So we can definitely store that particular material eventually for the further testing, and then eventually the process continues to give a proper prenatal advice, preconceptional advice to our patients. Sachin, thank you very much for your help, and all of us will be happy to have your services in Sholapur as well every 4th Sunday of the month. Huh? Thank you very much. Yeah.
First of all, I would like to thank Milind Shah sir. Sir told I'm a friend, but sir is much senior, and in fact, I learned a lot of clinical things from his side. Definitely, we will be there from January onwards. Every 4th Sunday, we will be providing the genetic counseling. As I mentioned, many techniques we are talking, like when to do which test is the biggest challenge across. We can discuss and we can give a genetic counseling report, and accordingly you can take a call further for it. Thank you SOGS, and thank you Milind Shah sir.
Thank you.
I request Dr. Archana Shah ma'am to please felicitate Dr. Vandana Bansal ma'am.
Yes. Sir, थांबू एकदम. Sir, stay back. Yes. Good. Yes. Dr. Vandana Bansal is always ready to come to Sholapur, and her train got delayed, and Sumit was saying मुझे station पे जाना पड़ेगा because she's my teacher. I'm like, good. That's that much love you again actually from all your students. Thank you very much, Dr. Vandana. Even Dr. Monica. Yes, she's also a student of Dr. Vandana Bansal. Yes, thank you.
Thank you all the dignitaries on the dais.
I must congratulate sir for doing such a good program in such short time. He is a big organizer and a good people's person, and he is the best person now for our presidentship also. So we are all with you, sir.
I request Neeta Madam and Milind Shah sir to please felicitate our chairpersons. And thank you Prajakta and Ashwini for being the MOCs.
Dr. Monica. Thank you, chairpersons. Thank you, Milind Shah sir and Gogate madam. We move on to our next